Hi everyone, and welcome to our very last seminar for this academic year of the PhenoLab. Thank you all for being here today. The proud people, the proud participants who resisted till the very end of July, and I really appreciate it very much. As anticipated in the email which circulated in the last days, today's, yes, of course, I will have my presentation, but also spend some words on the future of the PhenoLab and on a series of novelties that are going to happen. But we will discuss about it later. So I prepared a PowerPoint presentation, and I'm going to share my screen. We should be this one. No. There we go. I think you can see my presentation from the very beginning, right? There we go. Okay. So today I would like to explore with you the issue of the embodied encounters in the context of prescription of drugs. In other words, I would like to focus on what happens to the fundamental characteristics which constitute our experience when we are under prescription of drugs, when we have to take meds, and because we received a certain diagnosis, or because the dominant paradigm in treating a mental health issue is still very much focused on drugs. Basically, my presentation today is focused on how phenomenology can reach the understanding and development of clinical encounter, and how it may be problematic deciphering intersubjectivity in the context of prescriptions of drugs. In trying to reach these aims, I've divided my presentation in 4 main sections. In the first one, I will introduce the theoretical framework of my reflection, briefly reconstructing the history of phenomenology and its recent adjustments to cognitive science and neuroscience in general. I will also clarify some key concepts at the heart of phenomenological enterprise. In the second section, I will address the issue of the intersubjectivity. And in the third one, I will focus on those elements which characterize the clinical encounter thereafter. Finally, in the last section, I will discuss how prescription of drugs may impact the intersubjective encounter. The talk I'm going to present you today is part of this volume 5, which is Psychiatry and Neuroscience Update. Volume 5 is merely interested in the topic from translational research to drug addictions and psychosis. So the volume has been edited by Professor Pascual Ángel Gargiulo and Huberto Luis and Mesosis Arroyo, and it's going to be published for the Springer Publishing House. So it's a very new work. Let's start from the fundamental, and I apologize if somehow I have to repeat something already familiar for some of you. But we have to start from the phenomenological framework. As we know, phenomenology is a method of inquiry that aims to describe the basic structures inherent in conscious experience, such as embodiment, causality, temporality, intentionality, and intersubjectivity, and to analyze their possible deviations. Conceived by Edmund Husserl as a method to investigate Once lived experience, phenomenology offers reliable descriptions of the structures of conscious lived experiences in accordance with how they are experienced, without the imposition of any external framework. This is widely known as first-person perspective. From a phenomenological point of view, subjectivity is never regarded as an object, rather than the focus of the phenomenological enterprise is on the form and construction which characterizes the giveness of the experience. By analyzing the mode in which our world experience is constituted, phenomenology is capable of detecting those critical points where this constitution is vulnerable and open to deviations that may also emerge as psychiatric symptoms. The very first step of the phenomenological enterprise, as you know, is the epoche, which is the recognition that our experience is always hidden by habitual beliefs and assumptions, what Husserl used to call as natural attitude. This natural attitude needs to be suspended in order to provide access to our primordial experience. This is possible bracketing the validity of our current convictions, paradigms, and beliefs through the act of epoche. The nature and scope of this methodological shift is not to deny, not to neglect, not to abandon or exclude reality from our research, rather than to focus more narrowly and directly on the phenomenological given. In the contemporary context, the phenomenology has been involved in important dialogue, both with neuroscience and cognitive science. And one of the most important outcomes of this dialogue is the growing field of neurophenomenology. Born at the end of the 90s through the fundamental contribution of Francisco Varela, neurophenomenology is a method of inquiry designed to understand the so-called hard problem of consciousness and its relationship with the brain through a stereoscopic perspective, in which neuroscientific questions guided by first-person phenomenological evidence, combined with the third-person neuroscientific evidence, can suggest new articulations of the phenomenological description. Another fruitful outcome of this dialogue is the enactivist perspective. And as we know, enactivism is a particularly complex approach to the conceptualization and study of the mind, in which accounts of brain activity, philosophy, biology, but also sociology are involved. Generally speaking, the enactive approach focuses on sense-making as an embodied and situated activity. For enactivism, cognition arises through a dynamic interaction between an acting organism and its environment. It means that, quoting Giovanna Colombetti, cognition is not inside the brain, representing information about the world, computing it according to internal rules, and eventually telling the body how to act. Connection is rather enacted or brought forth over time by the whole organism, not just its brain, situated in the world. And we will see in the last part of my presentation how this account of cognition conceived as something inside the brain affect also the prescription of drugs. The environment of an organism is enacted by the active exercise of that organism's sensory motor processes. According to enactivism, mental processes are embodied, involving more than the brain, including a more general involvement of bodily structures and processes, are also embedded, functioning only in a related external environment, are also enacted, involving not only neural processes, but also things an organism does, and are extended into organism environment, So basically, we have the so-called for-his approach to cognition. The introduction of the term enaction, as many of you know, is attributed to Francisco Varela in his famous book, The Embodied Mind, published in 1991. Varela proposed the term enaction to emphasize the growing conviction that cognition is not the representation of a pre-given word by a pre-given mind, but is rather the enactment of a word and a mind on the basis of an history of the variety of actions that a being in the world performs. The interchange between a phenomenology and an activism has contributed to an understanding of the mind in a novel way that breaks from the traditional Cartesian and computational models that have dominated and still continue to dominate science and medicine. The alternative perspective consists of a set of approaches that emphasize different versions of the basic consensus idea that the mind is not just in the head or in the brain, but that the explanatory unit should be the brain-body-environment system in a mutual and circular relationship. Through the works of the first generation of phenomenologists and psychiatrists who apply the phenomenological method to the understanding of psychopathological phenomena, and more recently through the contribution of scholars in the field of clinical phenomenology, it has been possible to carry the phenomenological toolbox into the field of mental health care, particularly to psychiatry. The introduction of the phenomenological method for the understanding and treatment of mental health issues involves a particular analysis of reality to provide relevance to the given and lived experiences. The aim of the phenomenological analysis is not to account for how the physical world gives rise to a first-person perspective, rather the opposite, how phenomena, including the objective world, emerge in the first-person perspective. As a consequence, psychopathological phenomena and the so-called abnormal mental experiences are not anymore conceived in a framework of a diagnosis-centered approach, rather as a coherent way of being in the world of the person. With the introduction of the second-person approach, or the so-called intersubjective perspective, recent researches in phenomenology and social cognition overcame the antagonism between a first and third-person perspective. In fact, while the first-person approach corresponds to the basic and pre-reflective experience of the implicit self-awareness, the second-person approach means a pre-reflective awareness of self and other, based on ongoing face-to-face interaction. It is in this rich and interdisciplinary scenario that we can see how a phenomenological approach to intersubjectivity may enrich the understanding and the development of clinical encounter. Let's see how. When we deal with the notion of intersubjectivity, we have to start with a very fundamental thing, which is the body, our body. The notion of intersubjectivity is central not only in philosophy, but also in cognitive science and neuroscience. In what follows, I will try to sketch this development of the notion of intersubjectivity through the lens of the phenomenological toolbox, but also using some account of enactive approaches. We can't talk of intersubjectivity without going back to Husserl. And for him, the foundational element of intersubjectivity, especially in the so-called second Husserl, is the body, conceived as a 0 point from which the perceived world and space are organized. Quote, the body, in virtue of what constitutive role of the sensation, is of significance for the construction of the spatial world. Thus, all the things of the surrounding world possess an orientation to the body, just as, accordingly, all expressions of orientation imply this relationship. Now, as we know, the body may be regarded as having a double nature. It may be regarded as a living and felt body, what in German is called Leib, as well as a material object body, what in German is called Körper. This is illustrated with a well-known example of the double sensation, the left hand that touches the right hand. This double consideration of the body, however, is far from being a kind of residual aspect of a certain dualistic Cartesian tradition. And to overcome this possibility, Husserl created a term in which both the aspects of the body are unified. And this is precisely the meaning of the Leib-Körper. The main tension of this word, Leib-Körper, is to express that the subjective lived aspects of our corporeality are intertwined with the material one. This double gaze on the body tells us something crucial about the nature of embodiment as an ongoing art continuously shaped by our experiences, by the relationships and interactions with others and the environment. I quote from Husserl, "Lived experiences are bound to the body. Yet it's clear that the physical subject is not primarily related to his corporeal body as a material thing, and is only immediately related to the lived experiences connected up to it. Rather, the reverse. The physical subject as a material thing as its body because it is animated, which means because he has a psychic lived experiences in which, in the sense of the apperception of the human, are one with the body in a singularly intimate way. Then we can say that the body is the condition of the possibility to meet the others and the world around us. It is from this consideration of the body that we can talk about intersubjectivity as the mutual exchange of thoughts, feelings, and experiences, both conscious and unconscious, between two subjects. The possibility of sociality, the possibility of comprehension, presupposes a certain bodily intersubjectivity. This accent on the direct bodily and affective nature of intersubjectivity shows how subjectivity only reaches its full relation to itself and to the world through intersubjectivity. And this latter only exists and develops in a mutual interrelationship between subjects that share a common world. In other words, the possibility of sociality presupposes intersubjectivity as such. A substantial step forward has been taken by Merleau-Ponty. It develops a conception of embodiment, which is cardinal both in phenomenology but also in activism. Embodiment means that, according to Merleau-Ponty, that the lived body is the constitutive element of our being in the world. I quote, "The body is the vehicle of being in the world, and having a body is, for a living creature, to be interwoved in a definitive environment, to identify oneself with certain projections and be continually committed to them. The body has a situational spatiality that is oriented toward actual or possible text. And this spatiality unveils the intentional relationship that the body has with the space. This lived body unveils the demarcation between the self and the others. It represents the point of departure of each experience and the counter. I quote again from the phenomenology of perception. The perceived world is not only my world, but the one in which I see the behavior of other people take shape, for their behavior equally aims at this world, which is the correlative not only of my consciousness, but of any consciousness which I can possibly encounter." Another important merit of Merleau-Ponty's meditation is the introduction of the concept of intercorporeality. What is intercorporeality? It can be defined as the pre-reflective intertwining of lived and living bodies, in which each one is affected by the influence of the other's body, as well as by the effect of reciprocal relations. This leads to a kind of embodied communication. I quote, "The communication or comprehension of gestures comes about through the reciprocity of my intention and the gestures of others, of my gestures and the intentions discernible in the conduct of other people. It is as if the other person's intentions inhabited my body and mine his." The account of intersubjectivity described so far is the opposite of any pure mental approach to this theme. In fact, such an approach postulates a fundamental inaccessibility to the other, whose mental states, emotions, and feelings may be inferred only indirectly, for example, as in what happened in the so-called theory of mind, according to which the brain appeared to be modeled upon an inner process mainly characterized by inferential or stimulative models. This tendency to rely on the brain to explain social cognition and social perceptions reduces intersubjectivity to an inferential or projective process encapsulated in the brain, overlooking interactions between the individual and their environment. Conceived from the perspective of intercorporeality and enactivism, intersubjectivity deals with empathy, understood as a kind of intuitive, implicit knowledge that arises immediately when we meet another person. And this implicit empathy underlies social exchanges. We may say at this point that embodiment is at the core of every gesture, action, behavior, and relationship we have. It is also through our body that we can perceive others through sensory modalities. This empathetic perception is rooted in our bodily awareness and interconnections with others and guarantees the so-called bodily resonance. How it is possible? To understand what bodily resonance is, we need to abandon the idea that emotions are only mental phenomena and that the world is bare any affective qualities. We do not live in a merely physical world. The experience of space around us is always charged with affective qualities. These affective qualities, also called affective affordances, are experienced by bodily resonance, which includes all kinds of local or general bodily sensations. There is no emotion without at least the slightest bodily sensations and movement tendencies. The body is a resonance body, a most sensitive sounding board in which every emotion reverberates. Bodily resonance acts as the medium of our affective engagement in a situation and connects people with one another in circular interaction. Different components of the affection, resonance, emotion cycle mutually influence each other, and this cycle causes corresponding reverberation in the brain. The continual resonance of brain and organism is the precondition of any conscious experience. In every encounter, it means that our bodily resonance is at work, even if it is at different levels and depends on existential and clinical conditions. Now we may ask how the prescription of drugs may impact the embodied encounter and alter the deciphering of subjectivity and intersubjectivity. Let's start from what characterizes the clinical encounter per se. The clinical encounter is always an encounter between existences, not only an encounter between a mental health professional and a mental health user. It's an encounter between two or more existences that must communicate and enter into a relationship with each other. In the space of the encounter, each participant can feel the presence of the other. And perhaps here you can understand why I put so much emphasis on the role of our bodily existence. We can feel the presence of the other, not only see through the eyes. The possibility to feel the other unveils our structural engagement with the world. Feelings are always embodied and are different manifestations of affectivity itself. They are the key structures of our affective states. Affects, I quote, are moods of bodily attunement to and engagement with the lived world. It is only through our affectivity that we find ourselves in a meaningful environment in which persons and things matter for us, and in which we care for them as well as for ourselves. Affect are the very heart of our existence. Another cardinal element of the clinical encounter is the atmosphere, which inhabits the pre-personal and pre-linguistic dimension that human beings experience mainly in a shared space. Defining what atmospheres are is a bit tricky because they have a certain ambiguity which may be defined as their principal characteristic. In our ordinary language, we use the word atmosphere to signify both external landscapes or internal ones. As such, atmospheres may be impersonal or transpersonal, referring to the environment or to one's own feeling. They may have significance for people's affective states, things, or spaces. Drawing on atmospheric phenomena, the atmospheres in clinical encounters are associated with affective qualities that we have seen are also bodily qualities, and may also be characterized by a certain vagueness, evading rational explanation and any measurement. Atmospheres, I quote, are neither something objective, there is qualities possessed by things, and yet they are something like belonging to the thing, and that things articulate their presence through quality, conceived as ecstasies. Nor atmospheres are something subjective, for example, determinations of a psychic state. Yet they are subject-like, belong to subject in what they are sensed in bodily presence by human beings, and this sensing is at the same time a bodily state of being of subject state. In clinical encounters, atmospheres are cardinal, and they are the intersubjective phenomena experienced by the participant in this shared situation. Atmosphere have a kind of a synesthetic nature. To perceive an atmosphere implies a certain involvement in a situation and a predisposition to this perception. For this reason, the training of mental health professionals in the recognition and understanding of changes in atmospheres may have implications both on the diagnostic side, but also on the therapeutic one, namely by reinforcing the empathetic patient-doctor relationship. Embodied presence, affective states, atmospheres, gestures, and dialogue are all vital components of the clinical encounter. The observation, description, and understanding of their disturbances are fundamental when clinicians must ascertain a psychopathological condition. In fact, when an impairment in one or more these components occurs, It may disrupt ordinary life and adaptive emotional function, provoking a series of abnormal psychopathological phenomena. Here, for example, we can also open the path for a question. What does it mean, for example, when in a clinical encounter, we move from the lived presence of meeting the clients, the mental health users in our room, and what is the difference when we met them online? Can we still talk about an embodied presence? Can we still feel the atmospheres on an online session? I leave these questions perhaps open to the discussion. Now, let's see all these elements, which are grounded on the very idea that the body is the fundamental, or at least one of the key structure of our subjectivity. How all these elements can change in the context of drugs prescription. Drugs impact behaviors and relationships, affective states, and the ability to get in dialogue. They affect both the relationships with the mental health professionals and the relationships that the person has with their own illness or condition. A well-recognized property of chemical substances used for recreational purposes is their ability to produce altered states of consciousness and concomitant changes in behavior by virtue of their action on the central nervous system. In evidence-based psychiatric practice, there is a gap between long-term outcomes and treatment safety. This gap is grounded mainly upon two biases. The first bias is to consider mental disorders as chemical brain imbalances. And the second one is the predominant role of the pharmaceutical industry in the scientific community. Psychiatric drugs are psychoactive drugs. Due to their neurophysiological effects, they change mental and emotional life and behaviors for the duration of the treatment. Psychiatric drugs do not target underlying diseases or symptom-producing mechanisms. They create an altered state of mental functioning that is superimposed or underlying feelings and behaviors. Mental distress is often viewed as a burden, as a disease to get rid of as quickly as possible and without pain. Medication fits very well into this view, providing hopes for a quick recovery or for quick fixes. However, in many cases, mental distress can become chronic and lead to long-term disability, while the meaning or the message carried by the symptoms is often ignored. Efficacy and effectiveness are considered the same, when actually they are not. As with any other substance, every time a psychiatric drug induces a certain altered mental and physical state, the characteristics of which depend on the nature of the drug taken. Some psychiatric medications produce pleasurable psychoactive effects. Others are more often associated with the experience of an unpleasant psychoactive effect. An important concern is that the continued use of drugs and the consequences of these on the activity of the central nervous system may compromise mental function. The possibility of adverse psychological and behavioral effects occurring after long-term use of other psychiatric medications has periodically been suggested, but has received little attention. The fundamental principle at the core of the prescription of psychiatric drugs and their use is that they are worthwhile only if the benefit outweighed the harm. However, this is not that simple to calculate due to the many factors that contribute to the psychoactive effects or to dependence. The treatment understanding of mental health issues is strictly linked to the need to reassess the model and rules in clinical practices, such as a drastic reduction in the prescription of drugs, a more careful attention to a person-centered approach, and a focus on treatment centered on patients' lived experiences and community-based interventions. And here, I would like very much to stress the difference between mental health professionals who are by training expert on some psychopathological experiences, and on the other hand, mental health users who are expert by experience of the condition they are living. This gap often remain completely ignored. And perhaps this could be also an occasion to see how these two different audience of people need to be in dialogue in an important healing journey. From a phenomenological but also hermeneutics informed approach to mental health, pharmacotherapy is evaluated as an important but not exhaustive component in the healing journey. And here we go back to Jaspers, to the general psychopathology, when he exhorted us in use the so-called methodological pluralism in the field of mental health. I quote, "We must guard against any one viewpoint becoming an absolute, even if such a viewpoint proves fruitful for research and might not now and then even be decisive for radical therapy." The biological paradigm at the core of contemporary psychiatry often forgets the complexity and the meaning of psychopathological phenomena, which may not be reduced only to brain affections and treated by a massive recourse of prescribing drugs. Drugs don't cure the underlying mental health issues. They treat symptoms and signs and may improve for sure the quality of life of people with a certain condition. Curing has to do with the process of recognition, which shows the essential dimension of the self, never isolated, but always embedded in a relational dimension with itself, with a certain condition, with the others, and with the environment. We must acknowledge that contemporary psychiatry is disease-centered. It means that the issue of the diagnosis and its treatment is at the core of the therapeutic enterprise, which is essentially modeled on drug efficacy. A disease-central model embraces the idea that drugs act on the underlying physical disease process. They are able to reverse a faulty physiological process into a normal one. This model is at the core of the way psychiatric drugs are currently named and classified according to the disease. So thus, there are antipsychotics thought to act specifically on the pathology underlying psychosis, antidepressants thought to act on the pathology of depression, anxiolytics thought to act on the pathological basis of anxiety, anti-manic drugs thought to act on the pathology of mania, lithium, another mood stabilizer, thought to act on the pathological basis of abnormal mood. But all of these raise many questions from a phenomenological perspective and call into question the very core of the relationship between the patient and the doctor. An important element that I would like to stress here is the difference among three different approaches: the phenomenological one, the psychoanalytic one, and the psychiatric viewpoint. While a psychiatry claims an idea of objectivity as something that can be achieved only by adopting a point of view from nowhere, psychoanalysis advocates an idea of neutrality, recognized the impossibility to be impassible to patients' experience. But both of them claim this idea of neutrality. On the contrary, phenomenology may offer the psychiatrist the tools to become aware of their own lived experience of the clinical encounter in a very specific way, stressing the role of the embodied dimension of each encounter and the necessary shift from a third-person approach to second-person one, a view from within the clinical encounter. From this perspective, illness always has an intersubjective dimension, which challenges the therapist's gaze. This allows the possibility of an authentic encounter between people, not reducible to a checklist of symptoms and to a series of drugs prescription to be renewed time after time. This possibility must lie in something different. Let's move very quickly to the conclusion of my presentation. It has been Gadamer, one of the last one, to claim that health is a moral enterprise. I love very much this quote. And health is not something that can simply be made or produced by doctors. As a moral enterprise, health requires clinicians and health workers to be equipped with a series of different tools. This is perhaps why a phenomenological-oriented psychiatry may be of great help in deciphering the disturbances of intersubjectivity as the origin of psychopathological phenomena. Human experience is the result of interpretation, not only of action. The interrogation of the significance and meaning of an experience is vital in our ordinary life, but can even be more central when the integrity of the self is undermined by mental health issues. In the contemporary context, phenomenology and also hermeneutics are often neglected in medical schools. Their study, discussion, understanding, and application usually happens among expert senior clinicians. Young generations of trainees are trained in neuroscience and pharmacology, which is, of course, fine, it's fundamental, but it's not enough. And very rarely they consider the mental as not as the results of the brain activity of biochemical relationships. In the context of mental health experiences, deciphering intersubjectivity is a crucial effort for any diagnosis and treatment. This operation is possible in the space that I like very much to call the betweenness. What is this betweenness? It's the space between the I and the soul, the patient and the doctor, the person and her community, the person and their own condition. This space conveys a sense of openness and an original bond with others, which allowed really to let intersubjectivity as an open enterprise and not something already reached and yet closed. I thank you very much for your attention.